Good morning, everybody. It is a thrill and honor to be here together with you at Women Deliver, and I know it's been a really busy conference, but I'm grateful that you joined us this morning at our 7 a.m. breakfast. I want to just first of all say thanks to Allison for the framing of the WHO Safe Childbirth Checklist, and also to Evan for acknowledging all of our partners that made this work happen. As was mentioned, over the past 5 years, we've been running one of the world's largest maternal newborn health studies with a lot of you who are in this room, so I'm glad to be able to share what we have learned. As you know, we've all made tremendous progress in reducing maternal mortality since 1990, and through the dedication of so many, we've shown that change is actually possible. But what we're seeing now is that we've hit a roadblock, and globally, we have to address this roadblock. And that roadblock is the lack of quality of care and failure to execute on proven interventions. The BetterBirth Study was a chance and an opportunity to try and to remove that roadblock to improve quality and outcomes. As mentioned earlier, the WHO Safe Childbirth Checklist was the core of our intervention. 28 key practices that should be done for every mother, every newborn, every delivery. And they address the leading causes of mortality for women and newborns. Using a rigorous research design, we followed more than 157,000 women and their newborns across 120 facilities in Uttar Pradesh. With the checklist and peer coaching and data feedback intervention that came into 60 of those facilities, when we looked at behavior change and adherence to the basic practices by providers, we see dramatic improvement. Improvement in some of those behaviors like vital sign assessment, postpartum hemorrhage prevention. The blue bars here represent the intervention facilities, orange bars in the control facilities. And you can see on the left-hand side of that slide, there's dramatic change that happened. Yet when we tried to look at mortality alone and look at the impact of the intervention on perinatal mortality, maternal mortality, and maternal morbidity, we did not see a difference. The average mortality rates and morbidity rates were not different in the intervention sites compared to the control sites. So if we saw adherence to practices improve but didn't see impact on mortality, our question is why? We wanted to unpack the data of 204 million data points that Evan alluded to really try and understand what happened, what's going on with facility-based childbirth, and how do we actually make a difference going forward. So over the past 2 years, unpacking these 200 million data points, we've been learning more about innovation, implementation, and drivers of success. And we have some of those key lessons we want to share with you all today that are in the report, and I will summarize them as briefly as I can here. Through the data analysis and summarizing of lessons learned from across the globe, we have focused on 4 levels of the ecosystem surrounding facility-based childbirth, and tried to focus on what matters most at each level. For the woman and community who should be at the center of the care that we are providing, power matters. For the birth attendant, not only her skills and competency, but her environment in which she is working makes a difference. For the facility, the readiness to take on change and intervention matters. And at the health system level, systemness, how it all connects together, makes the difference. So I'd like to unpack each level for just a brief moment. At the level of the woman and her community, we learn that the power dynamics at play between women, community, and the health system sets up facilitators or barriers to care seeking, preferences, expectations, and normalization of care. Our findings resonate deeply with what the What Women Want campaign announced yesterday as their top 10 requests, and their findings that were released last night. In the study, we observed that the median time from admission to delivery of the baby was a mere 105 minutes, such a short time to be able to intervene for the woman and her child. But we think that this data actually embodies the lack of trust of the health system, connection from antenatal care to postnatal to intrapartum care, and the connection to the health system more broadly. Furthermore, we saw that the more macro level socio-demographic factors deeply influenced health outcomes for women. In districts with high facility literacy rates, we observed lower rates of maternal mortality. Of course, information like this, how we think about our facilitators and barriers, should be accounted for in the design of our interventions and implementation strategies, but often are not. A key area for innovation going forward is really about integrating person-centered care for the woman, the newborn, and improving the connection from the facility to the family themselves. It's not only about the woman, of course. We have to think about the provider and thinking about the birth attendant. A skilled, competent healthcare professional, of course, is required to deliver with high-quality care for the woman and her family. And our interventions globally have really focused on training and skilling up providers. And these are all necessary, but they are not sufficient. We must recognize that the environment in which the birth attendant works really matters. Through interviews and observation, we heard from birth attendants who shared their concerns over lack of physical safety, lack of culture of safety to ask questions or admit errors, and rarely received praise. Only 11% of the 600 providers we talked to had said that they had received acknowledgement for their very hard work. Clearly, to achieve high-quality care, we have to engage beyond the off-site trainings and move towards more comprehensive approaches. The frontline birth attendants and facilities around the world are proud of the work they do. They are working to provide the very, very best quality that they can, but we need to make that job easier for them. At the third level, at the facility level, we found there was substantial variation in mortality across sites. Each of these bars represents one of the sites in the intervention and control. We wanted to understand why is there such vast variation. In some facilities, perinatal mortality rates were as low as 14 deaths per 1,000. And in other facilities, they were as high as 106 deaths per 1,000. Nearly 10% of all deliveries ended in stillbirth or a death of the child by 7 days postpartum. Now, historically, our facilities' needs assessments have focused on the easily measured outputs and inputs, such as the number of staff, the number of delivery rooms, the supply availability in the facility. So we looked at every facility metric that we captured in the intervention and control sites to try and understand how does this relate, does this explain the variation in mortality? And out of these 30 measured factors at the individual patient mix level, facility level, health system level, district level, only 2 of them actually mattered. What we found is it's not these things listed on the slide here, but actually often the overlooked, difficult to quantify factors about a facility's readiness to take on quality improvement initiatives. What is the leadership commitment? What's the facility capability and capacity? What is the organizational culture and social context about being able to describe challenges? These powerfully promote and hinder quality of care. To maximize the success of quality improvement efforts going forward, we really need to think about systematic facility-level readiness assessments to identify and fill the gaps in quality. And these assessments need to include more than just skills, but thinking about leadership, management, teamwork, communication, and other external factors. Again, another area of innovation going forward. Finally, at the health system level, we often think of the WHO's building blocks, the service delivery, the financing, the health force. And often the building blocks of the health system are in place. However, they may not be well integrated and cohesive. No one facility, one birth attendant, or other component of the healthcare system is responsible for all the gaps in care. The systemness that we think about is the glue that holds all these pieces together to ensure high quality care for women and newborns everywhere. In maternal and newborn health, we think that systemness is demonstrated through continuity of care, seamless integration from the antepartum, intrapartum, and postpartum care. But in the trial, we saw the lack of systemness play out. We conducted a maternal death mapping where we have detailed information on 98 women who died during the study to understand what happened to them in all the different places they went seeking care. From the frontline facility, the majority of women were referred out. And they were referred, and they ended up going to a variety of places in the public and private sector. We saw that nearly 25% of the women who died in transit on the way to a higher level care. And we have one extreme case of a woman on what I call a Homeric odyssey, seeking care for an OBGYN and a blood bank and transfusion all in one location. She ended up dying on her way to the 5th facility. This was the tragedy of system failure. This woman deserves better, her family deserves better, and we can make it happen. Systemness is the sweet spot of connection when we have care functioning well. The infrastructure supports the care teams to make care happen by intention, not by accident. Areas for focus and innovation to achieve systemness include moving beyond the standardized protocols towards optimizing them with continued strong communication and connections to that higher level care. The key findings from BetterBirth trial and the completed analyses drive us to think more holistically. The lessons learned emerging from this health systems innovation work points us towards the key steps to achieve maternal newborn quality of care going forward. Now, the report has much more detailed information and a lot of additional analyses, but the 5 key takeaways we have are these. First, we need to integrate person-centered care for women and newborns and recognize the necessity of respectful maternity care. We need to prioritize quality of care, which has been a global mantra that's been initiated, but we need to move beyond that access to care, focusing on the content and the technical quality. We need to harness data. I was excited to see Allison mention the portal that was just launched, where it's just trying to aggregate information. We have many, many data streams of information being collected around the world. It's great that we have the information, but now we have to work on data utilization and how we make that evidence for action at the front lines, and then aggregate that information going up, making it useful for providers and managers at the facility level themselves. Fourth, we need to continue developing tailored implementation. Interventions require an implementation pathway, and they have to be adapted to the local setting. We must be creative and move beyond one-size-fits-all programming. And finally, we need to apply systems thinking. While we can have targeted approaches, we must think about how that intervention interacts across the health system and think more broadly. I think about this woman when I do my work. It all comes back to her pathway as she moves from her home to the community to the health facility and the interaction in her experience of care. The microcosms that lie in each of these levels of care, from the community and home to the facility level, sometimes seem to have a little life of their own. But it is the interconnections or the systemness across the levels of care from home to health system that will make the impact going forward. Innovation and systems science are the next big opportunity to advance human well-being and health. We know what to do. We know the care that women need for labor and delivery and childbirth services, and more broadly for their health more universally. Now we have to focus on delivering that care with excellence for every woman, every newborn, everywhere. Thank you.